Good afternoon. Welcome everybody. Please allow me to welcome Dr. Ahmed Bamaga, a consultant pediatric neurology and neuromuscular assistant and professor in King Abdulaziz University, and Dr. Hind Najashi, assistant professor and neurology consultant in King Abdulaziz University in Jeddah, to start our third session for today about neuromuscular junction disorder. I hope you all enjoy the session. Thank you.
Yes, dear, welcome to the third session. Just after the session, I will just will announce about the winner for the best posture.
Assalamu alaikum. I think we're going to start, we're a bit late, so we're going to start with Dr. Isa Shrougi. Dr. Isa is Senior Consultant Neurologist and Chairman of Department of Clinical Neuroscience في Manama, Bahrain. He's going to talk to us about myasthenia gravis and myasthenic syndromes. He will give us an overview. Thank you, please.
Well, thank you very much for the introduction, Mr. Chairman. And hi to everybody, and I'll thank the organizing committee for inviting me to give this talk. This talk will be, hopefully it will be brief. I also have a plane to catch, and sorry I won't be able to also take your questions for it because I have to leave directly after this lecture, really. So my task is to just give you a little brief about myasthenia gravis that you all familiar with. I mean, doctors like to treat myasthenia gravis. They think they know about it, and they recognizing the symptoms. The patient respond well in most of the cases. They put them into treatment, and they combine drug. However, this combination is also sometimes has its own drawback. I should really say that before 1958, it was, as the name is, what you call means gravis. It was myasthenia gravis. So the mortality was so high in this disease, as the grave or the gravis is denoting. And before 1958, they said about 30% was the mortality rate. Well, nowadays it is zero, I should say, with the current understanding of the disease and the medication, the effective medication that really we have, really. So saying this, really, as you all know, the myasthenia gravis, it is one of the brightest example of autoimmune disorder in medicine. I mean, as I always say, the rheumatologists always brag about their disorder, about having the autoimmune disorder, understanding it. But I think us, as a neurologist, we have the myasthenia gravis being the brightest example of organ-specific, really, autoimmune disorder where there is autoantibodies against the nicotinic receptor of acetylcholine. Well, the 1985 was a history for neurologists dealing with myasthenia gravis. 1985 was the Vincent and what you call a Newsom had discovered and described for the first time in history the acetylcholine receptor in their seminal really article in the GNNP. And after that, we had a gold standard, what we call tool to diagnose multiple sclerosis. Well, the sine qua non symptoms of multiple sclerosis is weakness and fatigability. And fatigability is the one that typically affect the voluntary muscle they have, and basically mainly the ocular in more than 50 to 70% of cases, and the rest of the muscle. Now, it is serious, I should say, and what differentiates it from the other neuromuscular junction disorder, it is a post-synaptic disorders. Now, the objective that I will have, it will be clear. I'll just have a little bit, a few slides about the classification of myasthenia gravis. Then I'll just speak a little bit about the etiology of myasthenia gravis, and then a little bit of the clinical feature. And I will leave the management and the treatment to my colleague, Dr. Mohammed Falah, from Bahrain also. Now, it could be classified, myasthenia gravis, into four, according to four factors. It could be the age of the onset, or the presence absence of anti-co-receptor antibodies, and the severity, and the etiology of the disease. If you look at the age of onset regarding the myasthenia gravis being what you call the acquired type, really, you have the transient neonatal or the adult autoimmune. Well, the transient is what you call the children of ladies who are acquiring the autoimmune myasthenia gravis, and when there is a passive transfer of these autoantibodies to their neonates. Usually it's very transient, really, and in 2-3 weeks, the fetus usually recover well. However, and in a small chunk of these patients, I think they may require some what you call apidostigmir, and even some of the neonates have been require the plasmapheresis or even to be given IG. So as the slide in front of you is saying, only 10 to 15% of this infant can acquire this autoantibodies, and they can have this symptoms. Now, regarding the seropositivity and seronegativity, most of the cases of generalized myasthenia gravis are seropositive, about 85%. When we say seropositive, we mean acetylcholine receptor antibody, which is against the alpha subunits of the nicotinic receptor of acetylcholine, and or the nicotinic part of acetylcholine receptor. Well, as I said, 15% of these patients are not really, and they are not, so they are deemed as seropositive. And when they have seronegative, and seronegative, I will just seronegative to the acetylcholine receptor only. However, many of the other receptors and against or many autoantibodies is not discovered against many parts of the neuromuscular junction that I'll be just highlighting in few minutes about it, really. The one peculiar autoantibody has been described in 2001. It was by Vincent also and Hock as the MuSK antibody, which is muscle-specific tyrosine kinase antibodies. And this receptor, basically, or this autoantibodies, has been described in small, what they call part or small percentage of people with seronegative myasthenia gravis, really. Basically, it was also described that, or it has been discovered that the seropositivity with the MuSK also necessitate also a little bit of phenotypical features. One of them are being resistant to our current therapy, very favorable response to rituximab, really, being more female. They have poor resistance to thymectomy, and more predilection to bulbar symptoms, really. So it's more localized with people who has that. So if you have that phenotype of being a female with bulbar symptom, being resistant to the usual anticholinesterase and a steroid, please think about MuSK, especially if they are negative to acetylcholine receptor antibodies. Okay, now regarding the severity, I think everybody heard about Osserman. That was in 1958. He had his classification of the regarding severity, and he classified into four types, and the first being the ocular, and the second will generalize, and the third one, of course, with the fluctuating but severe, and the fourth one, if the patient, of course, will require more of ventilatory, what we call, of severe bulbar symptoms. Now, this has been modified, and this modified in 2000, and this is the recent, what you call, or the modified Osserman classification regarding the severity of multiple sclerosis. And you can see that it held some of them, but it has divided all the degrees into 1 and 2, or A and B, regarding is it more severe or less severe, being the fifth one, or the fifth grade or class, is the most severe one, with the extent, of course, especially if you require ventilation, artificial ventilation, okay? Of course, if you require NGT there, you are still in 4B. This classification basically used mostly in research purposes. Now, regarding the etiology, we have 4 etiologies. One is what we are describing now, and the commonest one, the acquired autoimmune. And then second, we have the transient neonatal, caused by the passive transfer of these autoantibodies from the mother to the fetus. Now, the third one is drug-induced. And we have a bunch of drugs really that really can exacerbate myasthenia or can induce myasthenia. One of the one of the common drug that can induce is the penicillamine. Penicillamine induced myasthenia gravis with a disorder which is an autoimmune, which mimics really myasthenia gravis in many instances. However, it can remit in 2 to 3 weeks after stopping this treatment. Really, okay. And the fourth one, as an etiology classification, is the congenital myasthenic syndrome, where there is some what you call either deficiencies in some of the component of the neuromuscular junction, either the presynaptic or postsynaptic, or something to do with the neurotransmitter and its function in the synaptic cleft, having all this disorder, having it from what you call since from childhood or from the fetal stage. Now, let me speak about the epidemiology of this one. And it's very well known that myasthenia gravis is bimodal, and it is of, they say, affecting young women and old male. And that's the one. So it is bimodal really, usually in the 20s and the 30s, and the old age being more than 50s, and the 60s usually the patients are having it. Usually you don't have it more than 70 years of age. However, there was a study really published lately, really in 2003, recently I should say. It is an English or a British study saying that really it is overlooked in patients who are more than 75 years of age. So please look for it really and suspect that, although the clinical study saying something else really. Now, just a few things about the neuromuscular junction. And this is a normal neuromuscular junction. And if you can see, of course, you have what you have the nerve terminal, which is the presynaptic. You have the synaptic cleft. And you have, of course, the membrane of the muscle, which is the postsynaptic part of neuromuscular junction. In myasthenia gravis, the autoimmune, what we are describing about, we are really speaking about pathology affecting the, I cannot, is there a pointer here or no? So, never mind. So you can see the postsynaptic there, and the postsynaptic muscle membrane, it is thrown into folds. So these are like folds. So they are not even, and you can see the fold, the postsynaptic membrane, what you call it, junctional folds. And these folds is very important for us as a neurologist and as people dealing with myasthenia gravis, because the acetylcholine receptors are really concentrated at the peaks of these junctional folds, really, junctional folds. And if you look at the terminal, already called the presynaptic terminal, which is the nerve by itself, it is swollen, and it contains vesicles, and these vesicles contain the acetylcholine, which at the acetylcholine, it usually adhere to the postsynaptic or presynaptic membrane, and this, what they call this aggregate or this adhesion of these vesicles of acetylcholine to the presynaptic nerve terminal require the influx of calcium. And so beside this, the sites of adhesion of this acetylcholine vesicles, there will be what they call calcium-gated or the voltage-gated calcium channel. And this is the site where you have an autoantibodies in Lambert-Eaton syndrome. So in Lambert-Eaton syndrome, there is autoantibodies against this voltage-gated calcium channel, which prevent the calcium from influxing the presynaptic part of the NMG, and of course the release of acetylcholine into synaptic cleft. Now, if this is how this is schematic representation of the acetylcholine receptor. So what's there in the middle? It is the ionic really channel, or the cation, the ionic channel, through which the sodium usually influx inside the postsynaptic part, the postsynaptic part of the NMG really. And you can see it's formed from 5 subunits, the 2 alpha subunits, and you have, of course, a 1 beta unit, and the other is just depicted in the front of you. The most important thing is the alpha subunits. What we are really immunoassaying now by our current, what we call lab, is the alpha subunit autoantibodies really against it. And alpha subunits is where the acetylcholine receptor really lands or binds, okay, for what? So if you bind the two alpha subunits, the pore or the cation channel really in the middle will open and the sodium will be influxing inside the presynaptic or postsynaptic part. And I don't want to go into detail, I don't have for the sake of the time really, and the adhesion of this autoantibodies to this receptor really will release a cascade of what you call of reaction that they will degrade this acetylcholine receptors. It will destroy them, and it will also lower their numbers, and this will lead us, of course, to what we have in our hand is the myasthenia gravis, the acquired one. So if you just bear with me, if you have this, if you look at this difference between the normal NMG and this abnormal one in myasthenia gravis, you can see the folds, the junctional folds, they are reduced really, and the number of acetylcholine receptors are reduced in number. And what happened also, even the synaptic cleft is also less really. Now, so the thymus, the thymus is very crucial, and they say 75% of patients with myasthenia gravis will have a kind of thymic what they call abnormalities. A small part of them are harboring a thymoma, and the rest of them are having hyperplasia. And please look for that. And when you have this one, and people are describing the muscle cell-like cell, what you call the myeloid cells, and their presumed role in the transautogenic process of developing myasthenia gravis. Many of the cells are just beside the T helper T cell, activated T cells, and the presenting cells or the antigen presenting cells that have, of course, a great role in developing what they call myasthenia gravis really. Okay, now, what's the new regarding autoantibodies? As you all know, we have acetylcholine receptor antibodies, and we have the MuSK antibody, LRP4. LRP4 is a new antibody that has been also discovered in 2011, and basically you require really this one. You require this one to have what you call to preserve the function and the quality of MuSK. And what MuSK does, MuSK usually is responsible for the aggregation and concentration of the acetylcholine receptors and vesicles in the peak of the junctional cleft. Now, a few of them remit, and I should say a small percentage of myasthenia gravis, even without treatment, can remit. However, usually in the first 3 years, and if remission lasts more than 1 year, and recurrent disease tend to be more progressive. And the isolated ocular myasthenia really, they will usually generalize, and 16% of them subsequently in the first to second year after diagnosed ocular myasthenia. Okay, now let me speak about the characteristic of the clinical feature of myasthenia gravis. I have only 2 slides I'll be finishing, and regarding the clinical feature of myasthenia gravis. As I say, it is a disease usually has bimodal peak, and usually for young women and old men really. And weakness and fatigability is a sine qua non of this disorder. Ocular muscle weakness, usually the initial, in many of these cases. And usually, the target of muscle really, if you have it in the order really, it is the ocular, it is the eyes, the neck, the limbs, and the trunk really. If you have it in that one, what do you call it? A craniocaudal direction of involvement of muscle in myasthenia gravis. Okay. And what's the most commonly involved muscle in myasthenia gravis? Well, the levator palpebral muscle, extraocular muscle, the proximal limb, and this one. However, the extraocular muscle, it could be the presenting one in about 50 to 90% of cases. And ptosis, it could be unilateral, it could be partial, and in most of cases it's partial or unilateral, which is fatigable. And the ocular pulses, you should be very careful. It can be a little bit deceiving sometimes. And you have to differentiate from the internuclear ophthalmoplegia. You have to differentiate from ocular motor nerve palsies and from gaze palsies. The two pupils are usually they are spared. And the intercostal muscle weakness is one that can cause orthopnea for the patient, and the deep tendon jerks are usually normal or brisk. This is always ask our resident, how about the myasthenia gravis, how about the reflexes? I don't know, they always say it is depressed. I don't know why they say depressed, but I mean, it is nice to know they are usually normal or they are brisk. Now, if you look at this one really, if you look at your left hand, you have the fatigable ptosis. Tell the patient to look for 20 seconds up, and they will have what you have, the fatigable ptosis. Here you have unilateral on the left side, while in the right hand, you will have what you call the famous Coogan-led retraction sign. Tell the patient to look down for 10 to 20 seconds or 30 seconds, and then tell him to look back to the primary position. Well, usually the eyelid will go up, but then it will track down. We'll have the lag down, the nystagmus, the ptosis, or can have, multiple twitches of the eyelid, which is affected. What do you call the Coogan eyelid twitches sign, really. Regarding the factors that increase weakness in myasthenia gravis, you can have them all depicted on the front of you, but usually what we have among our cases are the infection, physical exertion, and the hot temperature. They are the famous, or what they call the most common triggering factor for myasthenia gravis. And here the list of the drugs that they can have that can trigger or really exacerbate your myasthenia gravis. So please be careful, and with the drugs, with some antibiotic that also can exacerbate or worsen the myasthenia gravis. And here with the summary of the tests that use in diagnosis, everybody knows about the statin receptor antibodies. Everybody knows the mask and the phenotype I just spoke about. But very few do the ICE, the ICE test. I don't know if Dr. Kepler does it, but basically for patient who has ptosis, it's very simple. You just put an ice pack on the affected patient eye, and he will improve in 20 to 30 seconds. A troponin test, nobody does it now. Very few. We do it urgently. If we want to snitch the diagnosis very urgently. And if you have all the mean of resuscitation, I have a patient really who was really a niece of one of our cardiologists who had partial ptosis, and she wanted troponin test. Really, the patient, I did it for him, and he had a cardiac standstill. It's very horrible experience for myself, really. So the CT and the MRI basically is for the thymic
Dr.
abnormalities.
1 minute left.
So there are different diagnoses of myasthenia gravis. Please be aware of it. Basically, especially the brain stem and stem diseases, and the other neuromuscular junction disorders. And the Lambert-Eaton syndrome this is a famous what they call slide. What's the difference between them? Between the Lambert-Eaton and myasthenia gravis. One is presynaptic and the other is postsynaptic. It's our disorders, and you have the limb which is really which is weak and generalized, and the other one. If you do the nerve conduction study, we have the decremental test basically, and myasthenia. Why you have the incremental test, which is more and more, you have it in Lambert-Eaton, and of course you have the reflexes which are brisk or there, however they're absent. So let me just come to the mechanism, and the other thing, let me come to conclusion. So myasthenia gravis is an autoimmune disorder against the acetylcholine receptor, the postsynaptic one. It has bimodal peak of incidence. It's probably underdiagnosed, and people who are old, we understand more and more of the pathophysiology of the disease. That's why we are treating it more effectively. Rarely there is any mortality now due to myasthenia gravis. And however, of course, there is still what you call vague part or gaps in our understanding. how myasthenia gravis is occurring, and why it's becoming chronic, and the most important thing, how it's become really drug resistant, really. And this is will be dealt by Dr. Muhammad Falah. Thank you very much.
Thank you. So I think we're going to go back and forth between Bahrain and USA. So I would like to invite Dr. Mazen Dimashqi again to the stage. Dr. Mazen Dimashqi, as you know, is a professor of neurology and neuromuscular medicine at the University of Kansas Medical City. He is involved in multiple clinical trials or steering committee for clinical trials in myasthenia treatment, including rituximab in myasthenia. He's going to talk to us, enlighten us about refractory myasthenia and update on treatment. Please, Dr. Dimashqi.
Okay, great. This is good. Okay, well, I want to congratulate everyone on sticking behind and being here. I noticed strong participation still. So thanks for being here. Unlike in the other meetings, like in the US, people are not as dedicated, I think, in staying throughout the course of the meeting. So thank you for staying back. And thanks again for the organizing committee, Dr. Kapler and others, for inviting me to speak here. So I'm going to talk about refractory myasthenia gravis. I kindly agreed not to talk about the second talk, which is myasthenia gravis and subcutaneous immunoglobulin, in the interest of time saving, and because subcutaneous immunoglobulin is not available currently in the region for the most part. But I'll give you a brief snippet as an introduction of what you may not be missing, but what I was going to present to you, which is I did a study in 23 patients with myasthenia gravis, and they were on stable doses of immunoglobulin IV, and I put them on 9 weeks course of IV immunoglobulin, then converted them to subcutaneous immunoglobulin for 12 weeks, and most patients remained stable. This work was supported by patients with myasthenia gravis, by CSL Behring. I got an educational grant, an investigator-initiated study grant, and drug provided. And there are many people that helped the participating. It was a North American multi-center study, and at the time, Ahmed Abu Zinada was a fellow, and he helped out in this study. Okay, that's what you were going to hear about after this talk. Let's talk about refractory myasthenia gravis. My disclosures, you've seen them before, but what's the definition of refractory myasthenia gravis? This is from the guidelines, the consensus guidelines, which currently are undergoing revision by the MGFA. It talks about post-intervention status being unchanged or worse as a definition of refractoriness and myasthenia gravis. After corticosteroids and at least 2 other immunosuppressants. Notice the number 2. It doesn't say 1. It says corticosteroids plus 2 other immunosuppressants with adequate doses, adequate duration, meaning not a day or 2 of CellCept, but several months, for example, and with persistent symptoms or side effects. Side effects are important. It's not just that the myasthenia is not well controlled. What if they're developing with corticosteroids uncontrolled diabetes, hypertension? What if they're having GI severe intolerance with CellCept? Uncontrollable side effects, in other words. These triads, these 3 things put together define refractory myasthenia gravis, and the recommendation by the MGFA is that it's either chronic plasma exchange or IVIG or cyclophosphamide, possibly rituximab in these patients. And I'll walk you through those. Now, this is data about how frequently does myasthenia gravis become refractory. It's about 10%. In one of the series, which is a bit of an outlier, it says 15%. But the reason why I put that number there, not because I think the higher number is the correct number, but because they looked at several characteristics that may determine who's likely to be refractory. For example, younger onset, more likely to be refractory. Females, more likely. Thymomatous, more likely. MuSK-MG, more likely to be refractory. This is a cartoon, anatomical cartoon taken from this publication of the neuromuscular junction, just to highlight where MuSK is. And you can see MuSK in the green middle part here. If I get my pointer to work, I would show you. I think I have a pointer flying around there somewhere, but I don't see it on my screen. So it's that part of the top of your screen, MuSK. But basically, MuSK, LRP4, and agrin interact together, and what they serve as is a function to make rhabdin able to cluster the acetylcholine receptor. And clustering, as we heard earlier on from Dr. Isa, is very important for the function of those receptors. Now, immunoglobulin, what do we know about IVIG and myasthenia gravis? This is data from Vera Brill in Toronto and her group, where they looked at patients, treated them either for their myasthenia gravis with IVIG or placebo, and they showed that patients that received IVIG did better than placebo recipients. Now, interestingly, if you look at the overall effect, the benefit in QMG and improvement was small, but part of the problem is this study included people that had ocular MG and those that had moderate to severe MG, and clearly the benefit was much higher in people who had moderate to severe MG as defined by QMG that's over 10.5, meaning 11 or more. Now, in their second study, when they looked, the same group looked at comparing IVIG to plasma exchange, they learned from the earlier study. They decided to include only moderate to severe MG as defined by QMG of 11 or more, and these patients were worsening. They randomized them to IVIG or plasma exchange, and they demonstrated that there was no difference at a p-value, as there was no statistically significant difference between IVIG and plasma exchange in this patient population. However, I bring your attention to the red line there. You notice at day 14, even though IVIG mean QMG change was 3.2 versus 4.7, you look at different time points, always the plasma exchange has about 2 points better QMG compared to the IVIG. So my bias, and those p-values, they get 0.07, 0.08, as you see in the lower two columns, to lower two rows. That tells you something. Still, my bias is that plasma exchange is slightly better, more robust in its effect, particularly in crisis, but also in moderate to severe MG. Now, what data do we have about cyclophosphamide? This is from an IV cyclophosphamide study in 8 refractory MG patients where they were receiving 0.7 grams per meter square of IVIG. 6 out of 8 of them responded dramatically. There was some side effects listed here, as you can see. So cyclophosphamide, not a preferred drug. However, there's some data in refractory patients that it can help. Now, of course, we like to use other options. And in the form of other options, this is taken from a paper by Marino Stalakas published back in 2015 that shows you other mechanisms and targets that have been used, particularly in myasthenia gravis here. And I'm going to bring your attention to in the left lower corner to rituximab and belimumab. And these work on the B cells, whereas in one way, shape, or fashion. And then on the right corner, those in red, eculizumab and zilucoplan, they work on complement, which is important for the antibody-antigen interaction at the level of the acetylcholine receptor. So let me walk you through that. Rituximab depletes B cell, it targets CD20 cells. This is a study that Richard Nowak led out of Yale. It's an NIH-funded study. I was a co-principal investigator along with others on that study. And the goal was to take 50 patients, randomize them 1-to-1 to receive either corticosteroids with placebo or corticosteroids with rituximab. And the protocol for rituximab was the lymphoma leukemia protocol, which means 375 milligrams per meter squared IV weekly times 4. There was a repeat of that in 6 months. And this is basically the top line results. This is not confidential. The manuscript is not published, but the data has been presented last year at the American Academy of Neurology, showing that while the primary end goal was reduction of prednisone by 75%, and we were hoping to show that there's promise for rituximab, in doing so, 60% of the rituximab patients were able to achieve that primary endpoint, and 56% of the placebo recipients achieved that, so that there was indication of, therefore, futility of rituximab use in acetylcholine receptor antibody binding positive myasthenia gravis. This is not a study of MuSK myasthenia gravis. I draw this distinction because it's very important, as there's powerful data from case series and single case reports of the effect of rituximab on MuSK myasthenia gravis. What about belimumab? It's a human monoclonal antibody that binds B cell activating factor, and therefore this is a kind of cell suicide type of mechanism whereby cell dies. It's approved in the US for treatment of systemic lupus erythematosus. It has some hypersensitivity reaction, but generally minimal side effect profile. We participated as one of the sites in this study, and the data was negative. I can walk you through the individual description of the QMG, the MG composite, the MG-ADL. There was no signal of efficacy in this study. This is a study that's been published last year in the Green Journal. What about eculizumab? Now, this is an exciting drug, exciting but expensive drug. It's a humanized antibody that binds C5. It prevents cleavage of C5a and C5b. It's indicated in the US for the treatment of a blood in the urine at night condition known as paroxysmal nocturnal hemoglobinuria. And after that, it was studied in myasthenia gravis, and we were part of the phase 2 and phase 3 study that led ultimately to the approval of this drug in myasthenia gravis in the US. This is the REGAIN study, and these slides are compliments of Chip Howard, who is the principal investigator on the study. Shows you the general layout of the study. It's randomized controlled study. Half the patients got eculizumab, half received placebo for treating their myasthenia gravis. And this is from the primary data of the study. The p-value for the primary outcome, which is change in MG-ADL, which is one of the myasthenia gravis outcome, was not below 0.05. It was 0.0698. It was a trend. But the majority of the other secondary outcomes reached significance, and therefore the FDA, in its own wisdom, decided its right thing to do is to approve the drug for the treatment of refractory myasthenia gravis. And this is from the extension. There was an open label extension study after the completion of the initial study where the patients that got on placebo were placed on the drug. And what's interesting is that when you look at the red lines being patients that received initially placebo in the first epoch, which is first 26 weeks of the study, and you have the vertical line at which point in time those placebo recipients were given access, open label, to the actual drug. You see that the MG-ADL dropped down. A reduction in the MG-ADL means improvement, and that improvement occurred within 2 to 4 weeks after that transition. And another way to look at the data is to normalize it such that the 0 point is a reference point where it can show you the red group where their MG-ADL went down, whereas the blue group stayed the same. The blue group are those that had sustained benefit from initially being in the first part of the study on eculizumab and continued in the open label on eculizumab. The other important new development in myasthenia gravis and in refractory cases is thymectomy. There's been a huge debate about thymectomy. Is it helpful to people with myasthenia gravis or is it not? Now we know the answer. It is helpful. In this study that was led by Gil Wolf, and we participated in that study too at our site at University of Kansas, it showed 3 things, that study. First, that the amount of prednisone that patients need to be on for myasthenia gravis is lesser if patients undergo thymectomy. This is data up to 36 months, and I'm going to show you some hot off the press data that's come out this January about the data at 60 months for thymectomy. But prednisone dose is lower. Now the next question you might ask is, what about their myasthenia? Was it better? Well, this is data from the QMG showing that in the red line that the people that got thymectomy and prednisone did better than those that only got prednisone as their QMG. This is the prednisone dose being lower. The previous one was QMG, actually. So what about adverse events? Because we think of thymectomy as a major morbidity study. Patients get crises, get infections. Is that true? It turns out that the number of adverse events was smaller in the people that got thymectomy, that the rate of hospital admission for exacerbation was lesser. Therefore, it's a safe procedure to do. Now, this is data that's hot off the press in the sense, as you see in the bottom, this is coming out, EPUB ahead of press as of January of this year. data that Gil Wolf wrote, showing that at 60 months, there's a sustained difference in benefit, meaning that in this case, the QMG is superior still in patients who receive thymectomy 5 years out. Also that the dose of prednisone is still lower in those patients 5 years out. Now, so from this treatment standpoint, for chronic MG, we think of first line, second line, third line, fourth and fifth line drugs. And in green, what you see here on the screen are drugs that I think are good for refractory or interventions, because thymectomy is an intervention, that are good for refractory MG. Thymectomy, IVIG, plasma exchange, eculizumab, rituximab, not for AChR antibody positive MG, but for MuSK MG, and possibly cyclophosphamide. We have to include that on the list, though this is not a favorite drug of mine. I've not used it in myasthenia gravis, none of my colleagues. And we have a huge clinic of MG. We follow 300 patients with MG, and we have not used it. So now what about emerging therapies? Is this the end of the story? Well, the answer is not. These are the studies. Most of those are studies we're part of. I'm trying to think if there's a study we're not part of, and the answer is no. We're part of each of those studies in myasthenia gravis. These are ongoing studies. There's a study by Alexion looking at a longer acting drug. As you know, the eculizumab is an every other week infusion. This is looking at a different way of administration every 8 weeks. There's a subcutaneous immunoglobulin study that I completed. There's Grifols has 3 IVIG studies. We're waiting for those results. Ra Pharma is looking at another complement inhibitor and going after a phase 2 study completed that's positive. Likely they will do a phase 3 study. Argenx is looking at a drug that interferes with the FcRn, which is the recycling receptor. It's a neonatal Fc receptor. What it does is when Ig goes into the cell, it allows it to get out of the cell. So if the FcRn is blocked, then the Ig is trapped in the cell, and therefore Ig levels decrease in the bloodstream of chemical plasmapheresis, chemical plasma exchange. That's what you do with plasma exchange. Momenta has its own brand of Fc receptor blockade. UCB Pharma has another brand, and Catalyst is interested in expanding Firdapse indication into MuSK-positive myasthenia gravis. So to conclude, I think that MG trials are very hard to do, but part of the big reason is, and this is work that Dr. Abu Zinada and I and others collaborated on when he was a fellow at University of Kansas. He looked retrospectively at our experience in our myasthenia gravis clinic and found that more than half of the patients, or almost half of the patients, were able to get by with prednisone alone without adjuvant immunosuppressants, and were able to go to low-dose prednisone. So it makes it where, like you saw in the rituximab study, that many patients can achieve dose reduction without any problems, without additional adjuvants. But now we're having more and more trials in MG. There's a growing number of those. There's several options available for refractory MG patients, and many more therapies are in development at this stage. So thank you for your attention. I hope I stayed on time, and thanks again.
Thank you, Dr. Mazen. Our next speaker is Dr. Mohammed bin Faleh from King Abdullah Medical City, Al Bahrain, Al Manama. Welcome, Dr. Mohammed.
Assalamu alaikum. Thank you very much for this kind invitation, Dr. Aisha and Dr. Kubler. Actually, this is going to be just a continuation of what Dr. Isa started. I think he covered some of the slides already. Okay, thank you. These are my disclosures. So as we all know, most of the patients with myasthenia gravis will end up having acetylcholine receptor antibody positivity. And the numbers vary, but overall, 85% of all patients that we're going to see will end up having positivity for acetylcholine receptor antibody. And that's why probably it is wise in clinical practice to start by ordering just one antibody. And I know like some of us will order 2 antibodies, MuSK and acetylcholine from the beginning for the sake of buying time. But if you really think about the incidence and prevalence of these different varieties of myasthenia gravis, then you could just start with ordering 1 antibody and then go to the next if your first test was negative. So 8 to 10% of the rest of the patients will have MuSK positive antibodies. We have 5% who are really negative, but we think that these patients might carry low affinity acetylcholine receptors. In other words, if you change the way you test, instead of a radioimmunoassay, you do a cell-based test, you might get more positive patients. 1% or maybe more of the patients will have LRP, LPR positive serology. So the seronegative myasthenia gravis, if you read the literature, some people use this term to describe acetylcholine negative myasthenia gravis. And others will use it to describe both acetylcholine and MuSK negative myasthenia gravis. So in this presentation, we will restrict this definition to people who are just negative for acetylcholine receptor. So we have the MuSK, of course, the first group, MuSK positive myasthenia gravis. Then we have LRP4 myasthenia gravis. And as I mentioned earlier, we have the low affinity. Okay. Okay, thank you. So we have the patients who have low affinity acetylcholine receptor antibodies. And then we have the truly what we call triple negative myasthenia gravis. So you do the 3 antibodies, MuSK and acetylcholine and the LRP4, and they are still negative. We also now have new antibodies in myasthenia gravis. We have the anti-agrin, collagen Q, rhabsin, and the list keeps increasing. One interesting finding I read when as I was preparing for this presentation was a paper from Norway on the whether some of these adult onset myasthenia gravis have a congenital myasthenic syndrome presenting as an adult form. So probably it might be wise to think of young patients who are not responding the way they should be to immunosuppression and other modalities, maybe think about a congenital form of the disease. Now classification, it keeps changing, but now I think people are moving more towards an antibody-based classification because as we know more and more about these uncommon types of myasthenia gravis, we start having more clinical oriented approach when it comes to antibody positivity. So again, we have the acetylcholine receptor antibodies. These are highly specific for the disease, 85%, and then MuSK, which is the oculobulbar type, if you like, of myasthenia gravis. And the type of antibody is IgG4, and they commonly go into respiratory insufficiency. Then the third group is the LRP4 antibodies. And then we have the other less common types. If you decide to classify it by clinico-pathological classification, then it will be an early onset, late onset, acetylcholine positive myasthenia gravis, and then the thymoma associated is a different group, and then you have MuSK and the other types. So 85% acetylcholine receptor positivity, and then 8% MuSK positivity. But if you take the negative acetylcholine receptor antibody patients, then 40% or 50% in some series of these patients will be MuSK positive. Now we say that these are mutually exclusive. So if you have a patient who has acetylcholine receptor antibody positive, it's very unlikely to have also MuSK positive in the same patient. Although in one of the very nice posters I saw today, 16 patients from the Saudi Arabia series, 2 of them, they were double seropositive. And the double seropositive are usually more severe than usual. So radioimmunoassay is the typical way of testing for these antibodies, but we can do a cell-based assay if these are negative. So in cell-based, this is more physiological. So we get cells which are human embryonic kidney cells, and they express acetylcholine receptor antibody. We also put rhabsin, which will help in clustering of these receptors, and then expose the cells to the sera of the patient. And this way, you can diagnose more cases, both MuSK and acetylcholine receptor antibodies. I thought this is a very important concept, the agrin LRP4 muscle-specific kinase pathway. So basically, if you understand this pathway, you kind of remember more the types of myasthenia gravis that we see. So agrin is produced by the presynaptic terminal. It will bind to LRP4 antibody, and they both will activate the MuSK, and then MuSK, in addition to rhabsin, will cause clustering of acetylcholine receptor, and then the neurotransmission becomes okay. So you can imagine what happens if one of these components is missing or blocked by antibodies, the whole transmission is disturbed. So in pathology, if you lose MuSK, you get oversimplification of the neuromuscular junction, and you lose your acetylcholine, and this is why it is very pathological. So now I'm going to spend a few slides, some of the time talking about each individual type quickly. So MuSK is the most common, of course, type of the seronegatives, very common in females. So if you see a MuSK case, chances are it's going to be a female patient. And there is some association with the HLA-DR B1 and B1, 14, and 16. The age, rather than a bimodal here, it is more of a younger age of onset with a mean 36 to 38 years. We often see a thyroid disease with MuSK, and it tends to be a more severe disease. So we say that it starts in the oculobulbar region. Some patients will have an axial type of weakness, so head drop, respiratory failure, proximal muscle weakness as well. Sometimes it's very asymmetric condition rather than symmetric. And then one of the peculiar things about it is the muscle atrophy, as we all know. And it is thought that the muscle atrophy is because the MuSK antibody is inhibitor of cell proliferation in the muscle. It will also upregulate some of the atrophy proteins in the muscle. And this is very important for 2 reasons. One, of course, we could confuse MuSK with bulbar onset ALS or other lower motor neuron syndromes. And the other good thing about it is reversibility. Although you see a lot of atrophy in the facial and bulbar muscles and the tongue muscle, but potentially it is reversible with treatment. So it's IgG4 rather than IgG1 and 3. And here again, the titer correlates better with the disease severity. So we always think that acetylcholine receptor positive myasthenia, the titer is not related to severity. But in MuSK, it is usually related. So if you do it after you treat, you should see a reduction in the titer of MuSK. The positivity, it depends actually where you do the test and how you do it. And there are some cohorts from China showing a positivity of 3.8%. And I found one Italian cohort where the positivity was 47%. Diagnosis is standard. One thing about the hydrophonium test here, it is less sensitive than another type of myasthenia. And if you do the repetitive nerve stimulation and a single fiber, then you want to test the affected muscles, which are usually the proximal muscles. So if you do the distal muscles, you may get a negative test. Treatment, I think Dr. Isa and Dr. Mazen spoke in details about the treatment. So if you give mestinone, the patients may get worse at higher doses. So be careful, especially these patients that are having bulbar weakness. And if you give more mestinone and you're very enthusiastic, then you may cause more problems rather than benefit. So you can use it, but be careful with the secretions. There are some case reports of the use of 3,4-diaminopyridine, and the rationale is that it will increase the release of acetylcholine from the presynaptic terminal. I don't have experience with this, but I think there are some cases out there. Immunotherapy, these patients, they respond better to plasma exchange rather than IVIG, although you can use IVIG, but plasma exchange is probably comes before IVIG. You can use also the other immunosuppressants like an acetylcholine receptor antibody, but rituximab usually works better in these patients. So this is a good review of rituximab use for myasthenia gravis, published in Muscle and Nerve 2017. So it is comparing rituximab use in different types of myasthenia. So if you notice the treatment effect in the patients with MuSK, usually they respond much better than acetylcholine positive antibody patients. Thymectomy is not recommended because I think 2018 there was a paper in the American Academy discussing the role of thymectomy in MuSK, and it doesn't work because most of them, they don't have the thymic hyperplasia, and the thymoma is very rare. So do not do thymectomy if you have a MuSK positive patient. What about the outcome? Although it is refractory and you need usually 2 or more medications to treat it, still the outcome is good and they respond well to treatment usually. Now the second type of myasthenia is the LRP4 myasthenia gravis, and I thought I will discuss briefly this paper, which gives an overview of myasthenia in 10 European countries. So they took 809 patients with myasthenia. Some of them are acetylcholine positive, some MuSK positive, and the majority were double negative for the two. And then they did a cell-based assay trying to find the LRP4 antibody. They also have 110 patients who are other autoimmune disorders and 90 controls. And in this, in patients who are double seronegative, almost 20% were positive for LRP4 antibody. Another interesting finding is the double positivity. So you can have patients with MuSK who are positive for LRP4 antibody, patients with the acetylcholine receptor who are positive for this antibody. When you have like 2 antibodies, the situation is really worse clinically. Now, this disease tends to be a milder form of myasthenia gravis. The female to male ratio is 2.5 to 1 and tends to affect more younger patients, less than 40 years of age. No thymoma, and thymic hyperplasia is seen in 31% of patients, and you can have a normal thymus in 33%. Clinical features, in this study, 85% of patients, they presented with myasthenia gravis, Federation of America, class 1 and 2. So ocular or marginalized myasthenia, and 15% they were in the 3 and 4 category. They did not have any patient in class 5. So 2/3 they presented with bulbar or respiratory muscle involvement, and 34% with limb or axial muscle involvement. If you go to the subgroups, I just want to show that despite all this sophisticated investigation and cell-based assay, you still have a lot of patients who are triple seronegative. And I have at least 2 of these patients in my practice. And they are responding well to treatment, but they are triple seronegative. So response is actually good. You can use the standard pyridostigmine, prednisone, and other immunosuppression. And 35% they may go into remission. So the prognosis is good, actually, with this type of myasthenia. Now the last one is the anti-agrin myasthenia gravis. So agrin is discovered a few years ago, and it is thought to be a pathological antibody in myasthenia gravis. And this paper is by Zhang, autoantibodies to agrin in myasthenia gravis patients. So basically, they took 93 patients with myasthenia gravis, and some of them were already acetylcholine receptor or MuSK positive patients. And they wanted to know, do they have an agrin as well or not? And they did ELISA test, and these were the findings. 7.5% of these patients, they had anti-agrin antibodies.
2 minutes, Dr. Muhammad.
Okay. And some of them were in patients who are acetylcholine positive or MuSK positive. Now, we don't have much information about anti-agrin, like clinical features, whether it is behaving like the standard type of myasthenia, whether it is less severe, more severe. So in conclusion, acetylcholine receptor and MuSK are specific and well-characterized antibodies identifying 2 disease entities in myasthenia gravis with distinct pathogenic mechanism, clinical features, and treatment responses. Cell-based assays have improved our serological diagnosis of myasthenia gravis, and antibodies to other muscle antigens are found in a subset of patients, providing clinical and diagnostic information, but their utility as biomarkers in myasthenia is still unclear. Thank you.